Okay, we're going to go ahead and get started.
Okay.
Good afternoon, everybody, and welcome back to our 4-in-1 Zoom. For this week, we are doing shreds, and today we are going to be doing ortho. We have Technical Sergeant Michelle Bickers, Staff Sergeant Caitlin Hopkins, and Sergeant Wester, I believe.
Yes.
Joining us today, all at Lackland Air Force Base Ortho Clinic. And I will go ahead and hand it off to y'all, and we can get started. Go ahead.
Hello, everyone. Like she said, my name is Sergeant Bickers. I am currently stationed at Lackland Air Force Base. I've been here for a very long time, for about almost 9 years. But I recently shredded into orthopedics last year, which has been one of the greatest decisions I've made in my career field. In my career so far, is joining this career field. I have Sergeant Wester and Sergeant Hopkins. Hi. And pretty much we're going to discuss some of the things that we do in orthopedics for all of us in the clinic, kind of our day-to-day basis, or how we run the day through some of the things that we do in ortho that we do not do in the OR. And yeah, so we're going to start off with Sergeant Wester.
Like you said, my name is Staff Sergeant Wester. I just got stationed at Lackland from Langley Air Force Base. I've been in about 12 years. My situation a little different. I was a pipeline ortho, so I went straight to school. So I've been an ortho tech for 12 years straight. So I would say my experience in it, you work a lot with hand-to-hand with your orthopedic surgeons, your PAs, also some orthopedic nurses. We do a lot of mostly clinical work and casting and splitting. We do some suture removals. Also, we do go to the OR, depending on your base, but most bases, we're going at least scrubbing the back table from time to time, first assistant, depending on where you're at. And I'll introduce Staff Sergeant Hopkins.
Hi, I'm Staff Sergeant Hopkins. So this is my second time being back at Lackland. I was here from 2012 until the very end of 2016. From there, I PCS to Turkey, then Launchstoel, and now I'm back. So, I'm sorry.
Just some of the things.
All right, so some of the things that you get to learn as an ortho tech. In the clinic, you get familiar with reading x-rays and MRIs. We're kind of fortunate because we work side by side with the providers, and you really get more of a hands-on feel with everything that you see and you do, more so than you would in the OR, just strictly because your providers want you to learn. They want to see you progress. You also get familiar with injection site placements as far as, for example, we've got steroid injections that we do. We have visco supplementation that we do for our knees. Those are either on a cycle basis or once every 6 months, depending on the medication that they choose. And I'm gonna go straight to pros. Awesome.
So one of the things that, some of the things that is very beneficial as far as the pro is concerned is really working with your patients. You really do get to see treatment from the beginning to end when it comes to your patients versus, back in the OR, you only got to meet or work with that patient probably just once ever. So it is a pretty neat thing to get to work with somebody, get to be part of their treatment, and get to be part of their solution as well. They get to know you a lot better, and you build those connections. Honestly, getting to know your surgeon in clinic does come a long way. That is a huge pro that I found. Just discussing the cases, having the ability to get with them days before, and knowing exactly what to expect when you go inside of the OR for that specific case, that really does go a long way. And like just understanding the treatment And you learn a lot as you go. You really do get to become familiar with things that you probably wouldn't have never become familiar with, such as learning how to read x-rays. How she mentioned injection site placement, that's a huge thing. Getting to even experience more of an exposure when it comes to clinic work is pretty much of a pro for sure. And then obviously what we do mainly, which is casting and splinting, I think that is something that a lot of people don't realize when you're just a slick, that you don't realize we cast and we splint a lot in ortho. That is really our forte. Just the simple fact that your cast, it can make and break someone's fracture, or it can fix, it can be part of it is part of their treatment. So you get to see a fracture go from how it started to how you help progress it. So that is definitely a huge pro to be an ortho tech for sure. To discuss some of the cons that we see a lot. Talk about those.
Yeah. So obviously, yes, there are a lot of pros in this career field. But with pros, everything can be all good. So there are some cons. Our career field been notorious to be critically manned. Like I said, I've been in 12 years on probably 5 different bases, and I want to say it might have been 1 year where we had enough people to where they could say, okay, you have enough people in your career field, you can move. So with that, when you looking into like special duties or getting picked up for special duties, it's kind of tough to get moved because, like the Air Force always says, mission first. Also, the promotion rate is a little bit slower than normal career fields, especially surgery tech. You just have a smaller pot to pick from. So obviously there's a smaller amount of people that actually get promoted. I would say that's probably one of the biggest cons. Outside of those, I wouldn't say there's very much huge cons, unless you really don't like working with patients. But if you do like working with patients, and you like being hands-on, you like working with hands, you like, shop work kind of, is what I would say, it would be a great fit.
Just to discuss some of the day-to-day ops for our day in the clinic. Clinic hours 7:30 to 4:30. So it is a little bit different than the OR. OR tends to start a little bit later, and then you do have different shifts in the OR. Whereas in orthopedic, clinic life is just clinic hours, and I think that is a really good break from if you've been in the OR for a while to be able to be working clinic hours and not pulling call. There are bases that you go to, like you can pull call, and other bases in ortho tech. So definitely that does not go away. We start rooming our patients as early as 8 o'clock in our clinic, and we really just go on up until the last patient that comes in. We room our patients. We print out what we call our 600s. We pretty much go through their last clinical notes. We discuss with the provider beforehand, before bringing that patient back, what to expect for treatment if you're a follow-up patient. And if it's if it's a brand new patient we have never seen, we go through their last x-rays, just kind of get prepared for the treatment that we're getting ready to provide for that patient. Is there anything you want to add to our day-to-day?
So as she said, we pretty much see patients from beginning of day, end of day.
Yes.
We've got fracture patients. We have patients that come in for total joints. Injections is a big one. That's kind of the most common one here in San Antonio. A lot of fracture patients,
yeah,
especially since we work
do
so closely with METC. A lot of those patients end up over here just for silly things that end up happening. We do have a lot of good future career options to kind of look at with our career.
Yeah.
So if you want to go this route, you can try to apply for the IPAP program. A lot of the PAs, especially in the ortho clinics, are more than happy to work with you and teach you. Because I think, if I remember correctly, you have to have 100 hours of shadowing before you can apply. We've also got the NECP, which is the nursing enlisted commissioning program. You can, if you're interested in becoming a surgeon, that's always an option as well, which I've known many a surgeon who is more than happy to take you under your wing. And then you can also become a first assist, and you can get your orthopedic certification. That is, you can get covered with AFSC.
Yeah. And to discuss also about the first assist, what's really cool about being in the orthopedic career field is that exposure to being a first assist it's very much there, because you do kind of leave you're still scrubbing, but you come back into the OR more directly to assist the surgeon. So it really does help you with that first, if you want to pursue first assist and PA as well. Like she said, you do get to meet a lot of providers who really want to help you and take you under the wing and assist you with that route. Other than that, does anybody have any questions that they'd like to ask us? Let's see, we have one more question right here. Ooh. What recommendations do you have? Oh, okay. Well, that's a great question. I think something like what we're doing right now is huge, because for as long as I've been in, I haven't been in terribly long, but the entire time that I was in the OR, you didn't really get to hear about what an ortho tech did or urology tech did or an ENT tech did until you ask those questions to those direct members, to those members that are ortho techs. Spending time kind of maybe promoting shadowing in the clinics, and just everyone being a little bit more open to receiving OR techs that are interested in shredding out, so they can come and shadow in your clinic. Repeat the question. So the question that we just answered was, what recommendations or suggestions do you have for the new CFM to help increase members to shred into ortho? So yeah, so basically just more exposure, a lot more information, even something like this that could be repeated. So that way we all have, or not we, but our OR slicks have the opportunity to know more in depth what happens in the clinic life.
The next question we have is, would you encourage others to retrain into ortho and rock? I'm kind of biased since I've been ortho for so long. So I always say, anybody I talk to, I always say yes. Please retrain into ortho. It's so much better than the OR. But obviously it's your preference whether you want to or not. But for me, I believe you get kind of a deeper knowledge and understanding. Yes, it's just strictly orthopedics, and you don't really get that broad basic knowledge like from the OR. But I feel like you get a deeper understanding of at least that specialty. So I always try and encourage people to come shred over ortho.
Yeah.
Also, there's bonuses as well. I don't know how long that's going to be, but everybody likes money, at least I do. So that's always the plus side too. If you do want to cross train or something you looking forward to, and obviously we're always open for people to come.
So the next question is, do you ever bring slicks to the clinic to teach them how to cast and split?
We put it out there for sure.
So we definitely put it out there. I know in Launchstoel, we made a habit of bringing technicians down. And then back in the day, I know it's weird saying that, but before I shredded, they gave me the opportunity to come down and spend like a week in the clinic just to see what I was getting myself into. And hopefully we can continue doing that.
All right. Are you always just assigned to one provider? No, you're not. Most of the time, you're assigned to multiple providers in one day. So you can run up to 2 to 3 providers, especially, it depends on how your clinic is manned. If you're low on techs, like most of our bases are, you do end up running more than 1 provider a day, but that really just broadens your experience as well. It helps you think quicker on your feet, differentiate between providers and their styles. Another thing too is that in some clinics, you will find yourself working with podiatrists as well, which is a pretty neat specialty. Lackland, and a few other bases are a little unique because of that, because we do assist our podiatrists that come in as well.
Our next question is, how much is the bonuses and how does it work? I would say they have the SRB list on your virtual MPF, but from my experience with it, it's just mainly like an incentive for you to stay in the career field. So when you're up to re-enlist or extend, depending on how many years you actually been in your rank, they have like a multiplier for our career field. It depends on how many years you actually been in or how high that multiplier can be. Usually for us, it's between 1 and 3. So basically, all they do is multiply the amount of years you've been in by your base pay and by that multiplier, and that should give you the full amount of how much they will give you all at once. Depending on what rank you are and how many years you've been in as well, that depends on whether they give you all the money up front, whether they give you some of it up front and then the rest of it throughout your enlistment, or also on whether they give you any up front or they just give it all throughout your enlistment.
Can everybody hear him?
Can you hear me?
Yeah. Okay. Next question.
All right, so the next question is, do you find it less stressful than the OR? So I think that's kind of dependent on the case that you're doing. There have been days that I walk in and it's easy, clean cut. It's a simple case, just for an example, like a distal biceps. Super easy to do, kind of just repetition. But then there are days where you got to do a total and you haven't done one in 6 months, maybe a year. And it's kind of like you have to relearn the process. And it's not too bad. It's muscle memory, but just that initial like walking in kind of gives you those butterflies all over again.
And as far as just the tempo of being in a clinic versus being in an OR, I wouldn't say it's less stressful. The tempo is different, and you do get a lot more understanding of what you're doing when it comes to your patient's treatments. So I think just you get exposed to more knowledge, and I think that really does make it less stressful. Whereas in the OR, it does take a while to get proficient in every case, or and whatnot. So when you're specialized into ortho, I think that really helps with the stress that I found in the OR. So our next question: what are your thoughts when it comes to ortho PAs and podiatrists earn manning allocations? That's a good one. Well, I think I think it's definitely challenging to have podiatry that needs to be supported by our technicians. However, they don't generate a tech, so that makes it hard, especially when you're trying your best to make sure that you're not burning your folks out, and when you're asking for people or you're asking for assistance, if it comes to that, they're not realizing, or when I mean they, I mean possibly higher leadership or the people that would give us manning sometimes aren't aware that podiatrists don't produce a tech. So, and they don't count podiatry. So that really does create a challenge. And it would be nice, it would be great if that could be, different. But we do what we can with what we have. And usually I think, since I've cross-trained, that very resilient people come into orthopedics. I've met very tough-minded, resilient folks that really just like to work and make it work with whatever we have. So far it you wanna-
Yeah, the next question is, do you know the retraining process? From my experience, usually once you get accepted into the orthopedic program, they'll send you to Fort Sam Houston to METC.
Yes.
It's a 6-week course where they basically are teaching you casting, splinting. They teach you they don't really teach you a lot of the like clinic work. It's more focused on the casting, splitting, some wound care as well. But when you get to your first base, usually there's a year of upgrade training. When they start, when you're in ortho school, they only give you about 4 to 5 casts. But
Well,
I'm gonna pass that out. I'm gonna pass that off to her.
So Sergeant Wester was the pipeline, so he didn't have to go through that process. So when I applied, I went into my first and I went ahead and put in the shred outs that I was interested in. Ortho was my number one. What's required of you is pretty much immediately is to start getting a 422 started. Then honestly, for me, it was very fast. That's how quickly man ortho is, I assume, because within a week I got a date. So I've heard other people have waited a really long time from the moment that they apply. But like I said, for me, it was pretty fast. Got it approved through leadership. And then I was off to start my new class date. Did you have a similar or different?
No, it was the same with me.
What year did you retrain?
It was 2015. Yeah. So I retrained in 2015, and I think it was maybe 2 weeks from the date that I put in to the date that I got a class. And when I got my class date, I was gone like 3 days later. It was really fast.
Yeah.
I can get the next question.
Yeah.
All right. So next question is, in the OR, are you more of a first assist or man the back table? That depends on the surgeons, whether they have residents, and then your duty station as well. Here at Lackland, for the most part, we're working the back table. Sometimes we are fortunate enough that our provider doesn't have a resident, so we get to kind of be a little more part of the team. But that unfortunately is always the case. But we're ready to go whenever we're needed. So the next question we've got is, when you deploy, is it as an ortho tech or as a slick? So from my understanding, I haven't had the opportunity to deploy yet, but I will soon. You can go as an ortho tech or as a slick. It just depends on the mission's needs. And I think that's
as far as our CMRP, or what are our thoughts on CMRP scribing hours outside of your specialty? Yeah, I think it's pretty fair. Personally, just the simple fact that we've seen many times where technicians go as orthopedic techs or ENT techs the same way or an ortho tech has gone down range as an OR tech. So I think it really does go a long way, at least spending or making sure that there's some type of a focus when it comes to scribing outside of your own specialty. Are you meeting those requirements? Yes, actually we are. We currently have in our orthopedics clinic, we have our own process, pretty much just a ranking system as far as who's been out of the OR the most. We're trying to get them into the OR quicker than others, so we can get them up to speed. I think this is probably a new type of pressure that I could say that we're seeing on the specialties with going up to the OR, making sure that that's a focus year round. So for instance, in our clinic, what we do is we focus on a member on a quarterly basis. Once we have that member in there, have a good bite of their 96 hours, we start transitioning to our next member. But before we transition to the next member, we send that next member up a few times before it's their time to go permanent, or not permanently, but for that time period. Just so that way, especially for our more seasoned techs, we're not sending them to the OR without some assistance at first if they've been gone for a while. Another thing that we're doing here in Lackland, which is a little bit unique to what other places are doing, is that we are working on an ortho sharing market between ourselves and BAMC, which I think is opening a lot of opportunity for Lackland, Wilford Hall, orthopedic technicians and OR technicians to be exposed to things at BAMC and see things that our BAMC counterparts get to see and get to do. Currently, we're working diligently with our BAMC orthopedic leadership, and there's an MOU that has already been established, and so far it's gone very well. Just trying our best to get through this COVID difficulty so we can get back to that, because we started it in November, the process of sending our folks over there to BAMC and having their folks come over to us and get them in process and introduced to each clinic. But until we can get through this COVID stuff, we can't get back to that. But hopefully that happens soon. We can find a way even through COVID, because we definitely were benefiting from sending our techs over there and even having them come over here to us. So, and that will for sure help our CMRP challenges. Let's see, do we have any questions? So, yeah, so there's anything else that you guys want to ask us? Just one of the things I think we kind of skimmed over a little bit is casting. I don't think we've discussed it enough, but in tech school, we do our casting training, which it's a very focused training. I mean, you really learn a lot. You're almost, in my opinion, prepared to work on a patient as soon as you're out of tech school with how great the casting training is there and splinting training is there. I know when I left tech school and I came to Wilford Hall, or back to Wilford Hall to work in the orthopedics clinic, my leadership made sure that even when we had downtime or even if we had moments where we weren't getting enough fracture patients that needed casting, we were still casting 3 to 4 times a day, making sure that everybody is proficient. We started our own training. It's not our own training program, but it is to help with the training program in our facility, where we did cast wars. So basically, all of our technicians teamed up every Friday, and we started casting each other, and just kind of having one person go through each cast and making sure that we're meeting the criteria. We tried our best to stick to the criteria that's trained in tech school, just so that way we can get people signed off quickly or appropriately, and then and keep our skills up as well. When there are no more questions, oh, okay. So, all right. Let's see. At Wright Pat, Master Sergeant Richardson has his techs getting certified in casting. Do you think that should be a future requirement? That would be,
sure.
Yeah, absolutely.
For sure. I think anytime you can get, any sort of, casting is like the main base of our job, period. Wherever you go, that is the main focal point. If you can't do that, then, it's kind of hard to go different places and to be on your own without having that like base knowledge and stuff. So I definitely do think that should be a requirement for the people.
I think it also sets you up for if you were to ever decide to separate, getting out of the military and you want to continue your future in ortho, having a captain certification or having a certification would be great. Sergeant Bunce, I think that's a great idea. If you don't mind us getting in touch with you offline, because that's pretty. I think if we were to implement something like that in every clinic, we would have a lot proficient techs PCSing around, and I say this for us. No funding, yes, no, but AFSC does help if you want to pursue that independently. But I think for us, we're stationed at Wilford Hall, as you know. Sometimes it is a little hard to stay up with your requirements if you're not actively doing it, or if you don't have leadership actively setting you up to get your requirements done. So when we PCS, the last thing we want is to send someone from Lackland and to another base and not have them be as prepared as they should be. So having something implementing like that is definitely beneficial. All right.
All right, so if we don't have any more questions, we're going to give it back to TSgt Kaloides.
Sorry about that. It was muted and it wouldn't unmute. Anyways, thank you very much to all three of you for joining us. Actually, before we close out, I'm going to hand it off to Senior Master Nahar. He has some information he wants to share with everybody. So, Sergeant Nahar, whenever you are ready, go ahead, sir.
All right, am I on?
You're
Yes.
good.
All right, nice. I get to hear myself. Hey, so hello everybody. Thank you for Sergeant Baker, Sergeant Hopkins, Sergeant West. Thank you for sharing that information. Greatly appreciated. I definitely like to share knowledge and your expertise and your experiences on helping to educate all of our 4-in-1, especially obviously the slicks that may be potentially considering shredding into that specialty. And some of the questions that I asked pretty much are trying to solve an issue with manning within ortho. In case you guys didn't know, the manning percentage for orthopedics is about 70%. The goal is to try to get those numbers a little bit higher so that there isn't a deficit in any one base to be able to run their normal mission ops, running the clinic, being able to support their docs in the operating room too. So thank you for that feedback. Anything else that you guys may have in mind, please don't hesitate to send it my way. With that being said, I am officially the new career field manager for the 4-in-1s. I am doing a turnover with Chief Caldwell, and hopefully soon we could start working on ideas, and I got a lot of them, to try to change our career field, things that may be in the near future, but also as well as where I see our career field needs to be for the future. I know one of the things that was brought up, you guys mentioned, we all know for the most part, most shreds work in the first assist, role when they're working with their docs. So how can we give them that ability to be able to use that skill and possibly pursue a first assist? I know there's folks out there that have their first assist, but that's not recognized in the Air Force, right? We all know that our CDC says that only physicians can be first assist, and that's what's kind of keeping us from technically allowing y'all to perform in that role. I mean, those are some things that I've thought about and try to see maybe at the Air Force level if we can get credentialing at certain bases to use that as a potential platform to see if that may work. Because as of right now, there is no official first assist surgical tech out there, even though the program is a civilian institution. And I know some folks either already have it or working toward that. I would just hate for somebody to get that first certification and, it doesn't happen. So it's definitely helpful for those folks who are transitioning as they separate from the military, because it's obviously worth it, because I did work for almost 10 years at civilian hospitals, and I got to work with a lot of prior military or civilian scrub techs that were first assist, and definitely is value added for the surgeon to have all the information, whether it's the case, whether it's instrumentation, what procedure, what could potentially change, and that changes the obviously the outcome of that patient care, but also the efficiency of how we can perform that particular role. So you guys should be seeing a bio come down from your leadership. I just sent it probably about 2 hours ago, just so you know who I am, where I come from. Obviously, I haven't been able to reach out to every single 600 and something surgical techs that are out there. Some of y'all that are in this platform know me very well and know that I'm very passionate about our career field. I've been in almost 20 years, so be 20 in August. Oof, it's going by fast, but you guys know where my passion is. And sometimes I try to shoot for the stars. If it doesn't, work out that way, then at least we get to the moon. And you've heard that, mentioned before. I want to be able to provide some sort of, better platform, better situations that we currently have. A lot of times, priority comes into place, certain things that need to happen within the career field. So just know that I got a lot of ideas, and I have to obviously prioritize them as a new career field manager to say, hey, what's priority number 1, what's priority number 2, and what's priority number 15, and can we make that happen while I'm in this position? I'm excited. I will be PCSing. I'm currently right now at Nellis, and I will be PCSing to Falls Church, which is pretty neat because I wouldn't necessarily have other distractions that you typically have for previous CFMs, having to do different things and still try to manage the career field. So I think I'm in a better advantage when it comes to truly taking care of 100% of my time to the career field and to you guys. So I'm excited, and that's probably why you've been seeing my ugly face on these Zoom sessions, because this is something that I definitely support. Thank you, Sergeant Kaloides, for getting this thing going, and obviously we'll continue to do it in the future to try to educate everybody in the career field, so that the excuse doesn't come up. I didn't know that was an option, because I will call you out on it and say, come on, you're familiar with YouTube, right? I'm pretty sure that everybody will be saying yes. So get on YouTube and see the replays. You don't have to see this information live, which that's fine. I understand that people have things going on and it doesn't work for everybody, but please educate yourself. If you're a supervisor, educate yourself if you're considering one of these positions, because this information is important. If not, we wouldn't be spending this time and having all this effort to make things better for our career field. With that being said, thank you guys for this time. If y'all have any questions and concerns, please reach out to your leadership and send me any information to make our career field better, and I'll consider it. If not, maybe I'm already thinking about it.
Okay, Sergeant Vickers actually messaged me, and she has one more thing she wants to talk about really quickly before we close out the session. So just 1 second. Okay, yes. Sergeant Vickers, go ahead.
We just really wanted to point out Sergeant Harlan and everything that he does. So for all my folks out there that would like to shred out, and you have any questions on orthopedics, and please reach out to Sergeant Harlan, because that's exactly who I reached out to. Sergeant Hawkins has reached out to him too to discuss things with our career field, and just especially when I was an OR tech and I wasn't really sure of the process, I was given his name as reference. So thank you, Sergeant Harlan, for helping us and helping us get into his career field for sure.
Okay. Sergeant Nahar, I have one more question for you, actually. Do you think, as far as InCorp goes, that there's going to be more going towards the ortho career field than other career fields, since they are the lowest manned?
So that's usually, can you guys, am I on?
Yes, you're good.
Okay. All right. So that's obviously the tool that is used to get our shreds healthy, is to use the NCORP, because we don't get enough volunteers to fill every seat. So that's why I've been asking some of the questions or suggestions that you guys may have, because here at Nellis, I have provided that opportunity to have some folks that are considering to shadow the clinic, and I've actually been able to get folks to go into ortho for that, and we're in the process of doing that. So NCORP, unfortunately, is a tool that kind of forces people that are haven't decided whether they want to shred, they want to stay in, they want to get out, and this kind of forces people to get out of their comfort zone and out of their comfort bubble, to say, hey, you still want to be a productive member of the Air Force, but we need you to go into this specialty because our numbers are not where we need to be. Unfortunately, until we get enough volunteers consistently, then we have to use the NCORP, where we have to pick members, senior airmen staff sergeants or young tech sergeants that are in that nice window to say, hey, let's shred them so that we're able to get more return of investment and keep them in the career field. And like it was mentioned before, there are bonuses out there for you guys. Actually, the new SRB list does not look very good for the shreds. They actually dropped, but something's better than nothing. So obviously take advantage of that. Find a way to do an extension to where you still meet the requirement for the course, and make your decision, to re-enlist and get that bonus. But again, NCORP, unfortunately, right now is still the best option to fill some of those vacancies that we have across the AFMS.
Okay, sir. Thank you very much. We're going to close out this session. Tomorrow for ENT, joining us will be Tech Sergeant Dominguez.